Welcome. My name is Dr. Keith Mankin from NC Pediatric Orthopedic Sports and Spine in Raleigh, North Carolina. It is my pleasure today to present genetic prognostic testing for adolescent idiopathic scoliosis, clinical experience versus historical controls. This is a paper initially presented at the annual meeting of the Pediatric Orthopedic Society in May of 2014. By way of disclosures, I am a member of the Transgenomic Speakers Bureau on ScoliScore. However, no direct support was provided for this study. The study was approved by my practice group, and each family gave consent for use of the data. Scoliosis, or curvature of the spine, is a very common and ubiquitous problem. Fortunately, the vast majority of patients do not have worsening of the curve as it remains mild and do not require any treatment other than observation. However, current methods of determining the behavior of a specific curve may at times be inaccurate, with predictive values as low as 65%. Patients nowadays are most often observed with multiple visits and serial x-rays, leading to a high cost of care and a high rate of radiation exposure. Testing based on the human genome has been promising in predicting the behavior of small curves. 53 discrete genes have been associated with progressive scoliosis and have been incorporated into a test called the ScoliScore. This test is indicated for mild curves less than or equal to 25 degrees in children with growth remaining. The test generates a score between 1 and 200, with the lower scores having a lower risk of progression and higher scores having higher risk. In fact, validation studies have shown a 96% positive predictive value for progression of the curve with high scores, 181 to 200, and a 99% negative predictive value for low scores between 1 and 50. This has led to so-called actionable results for the gene test, as per expert opinion, with the low-risk group leading to the possibility of fewer clinic visits and x-rays, and the high-risk group hopefully allowing closer observation, counseling, and the ability for earlier intervention. The rationale for this study is that prior studies have used a clinical endpoint of progression of the curve to greater than 40 degrees, but have not addressed prediction of the need for treatment, particularly bracing, which may occur at less than 40 degrees. Also, prior studies have not reviewed actual numbers of clinic visits or x-rays and have not compared the clinical course of ScoliScore patients versus controls. In this study, I collected the data on 152 patients tested with ScoliScore in my practice over a 2-year period. The data were collected for Cobb angle, which is the amount of scoliosis, both at the presentation and also at the final visit before collection of data. The number of clinic visits and x-rays were noted. Patients were also noted whether they had progression to treatment, either bracing or surgery, and whether they were skeletally mature at the time of data collection. These numbers were compared with 75 age-matched controls presenting with mild curvatures who had not had ScoliScore testing. This table demonstrates demographic distribution between the various groups in the study. Age of presentation and female to male ratio was roughly the same between the control and ScoliScore groups. The substratification of low, intermediate, and high risk showed roughly the same age of presentation, although interestingly the high risk group was all female. In terms of skeletal maturity, this was not available for the control group, and the entire ScoliScore group demonstrated 25% who had reached skeletal maturity at the time of collection. The distribution of ScoliScores by risk stratification is demonstrated in this group. The scores are broken down to low 1 to 50, intermediate 51 to 180, and high 181 to 200. Remember, the actionable ranges are the low and the high groups. The numbers are as seen, with 55% being in the low group, 12% being in the high group, and 33% in the intermediate group. This pie chart shows the distribution as a comparison to the other groups. It's worth noting that 67% of the scores fell into the clinically actionable range, either low or high. In terms of result by curve progression, there is a notable difference in the curve progression between low risk and high risk, which is what would be expected from the validation studies. In fact, there's a clinically significant difference, with the average change in the low risk only 1.84 degrees and in the high risk 12.2 degrees. Of note, there is no significant difference in the average change between control and ScoliScore, as would be expected. In terms of clinical outcomes, namely x-rays, clinic visits, and whether the patients proceeded to surgery or bracing, there were marked differences between control and all the ScoliScore groups. The average number of x-rays was significantly decreased in the ScoliScore groups versus control, from 3.9 in the control to 2.7 in the ScoliScore groups. The most marked difference, however, was between the low-risk group and the high-risk group, where the low-risk group only received 1.5 x-rays versus 5.3 in the high-risk. In terms of bracing, there was no significant difference between control or ScoliScore group, but there was a marked difference in the low-risk versus high-risk, and in fact all other groups. The low-risk group had no bracing versus 72% in the high-risk. In terms of surgery, 3% of control patients went on to surgery versus none in the ScoliScore group, although the statistical significance of this fact is hard to determine because of small numbers involved. Although only a small portion of patients, 25%, had gone on to skeletal maturity by the time of collection of the data, the statistical trends had been maintained. 100% of the patients in the high-risk group who had gone on to skeletal maturity had required bracing, and none of the patients in the low-risk group. In summary, this study corresponds with previous reports as to the effectiveness of ScoliScore in predicting the clinical course of a small scoliosis curve. Specifically, this looked at a significant difference in the clinical course between low-risk and high-risk ScoliScore patients, and for the first time demonstrates the difference between ScoliScore patients and controls. It's worth noting that 2/3 of the patients had what we would term actionable ScoliScore results, either low or high risk. Also, the high-risk group had a significantly higher increase in the Cobb angle over the study period versus low risk, as predicted by the ScoliScore. Of equal importance, there were statistically fewer x-rays, with a trend towards fewer clinic visits in the entire ScoliScore group when compared to controls. This was especially true in the low-risk group, which had a significant reduction in x-rays versus all other risk and control groups. In terms of progression to treatment, no patient in the low-risk group progressed to treatment, either bracing or surgery, whereas 72% of the high-risk group went on to require bracing. This number rose to 100% by the time of skeletal maturity. It's also worth noting that no ScoliScore patient went to surgery versus 3% of the control group. In terms of discussion, and in distinction to prior studies, I chose a positive endpoint in this study to be the need for treatment for these children, either bracing or surgery, rather than the arbitrary progression to greater than 40 degrees. I felt this would more accurately evaluate the effect of the test on clinical practice and would provide a more real-world effect. It should also be noted that patients were braced for standard parameters of a significant curve progression, and that the ScoliScore itself was not used as a factor in the decision at this time. Obviously, results may change as this cohort progresses to skeletal maturity, but since the mature subset, as seen on prior slides, had similar treatment rates, I anticipate that the study results will remain valid and may improve. I think ultimately the high-risk score may become an important determinant as to the need and effectiveness of early bracing. But further longitudinal studies are needed to assess this, as well as the effect of genetic testing and the ScoliScore on bracing and surgical rates. Thank you for your kind attention.